died. When's the funeral?
Whenever I get home to throw it out in the trash, I guess.
Yeah, that's what it is.
All right, back to this. Your heart is a small organ that contains 4 chambers. Your left and right atria and your left and right ventricle. 2 associated with each circuit. So your 2 right-sided chambers are associated with what? And your left chambers are associated with what? Your right atrium receives blood from the systemic circuit, and your right ventricle discharges blood into the pulmonary circuit. While your left receives blood from the pulmonary circuit, and the left atrium, and the left ventricle discharges to systemic circulation. Now, depending on who you talk to, there's different ways to phrase the question that I just asked. To me, right-sided deals with pulmonary and left-sided deals with systemic. That's just in my brain how it works. You can say both atria deal with pulmonary and both ventricles deal with, or opposite. The right atrium and the left ventricle deal with systemic, and the right ventricle and the left atria deal with pulmonary. It all depends on what you want to do. For me, for this class, how we speak, right will be pulmonary, left will be systemic. So if I'm referring to something, that's how I will interact with that. The beating heart, the atria contracts first, okay? Ventricles contract at the same time, not as the atria, but the lower ventricles contract right and left at the same time. And that ejects equal volumes of blood. If we don't have equal volumes of blood leaving the ventricles at the same time, what does that mean? We don't have the same amount of blood reaching the atria at the same time, and it's going to cause a preload or afterload issue, which we'll get into preload and afterload in a little bit. But if I've got more returning on one side than the other, what is that going to cause? It starts with a C and ends in HF.
CHF?
Good job, right? Because you're going to have a backlog somewhere. In case you didn't know, the heart lies in your chest. If that's new to you, we probably have a problem that you're in here. Lies directly behind the sternum. Contrary to popular belief, it's not under your nipple or any of that. The most far side is about at your nipple, and the rest of it is confined to below the sternum. Doesn't mean it sits directly here. It's offset a little bit, but it's not floating over here underneath your armpit. It's enclosed by the mediastinum, which is a connective tissue mass that divides the thoracic cavity into 2 pleural cavities. Enclosed in this mediastinum also is your thymus, esophagus, and trachea. The problem? How'd you get drill this back? Your heart is surrounded by something called the pericardium, which is a membrane that lines the pleural cavity. This associates itself from the rest of the organs in your chest. A week ago, I got to do the coolest shit ever and do a pericardial synthesis. Most nerve-wracking thing I've ever done in my life. But it was a pretty cool experience.
After he finger fucked somebody's chest.
I also did a chest tube and a simple thoracotomy as well. But yeah, out of all of that, the pericardial synthesis is probably the coolest thing ever. Because you've got about 2 to 4 millimeters of air before you fuck up real bad. And I was shaking like a leaf in a hurricane, just to be honest. Chest tube didn't bother me, simple thoracotomy didn't bother me. You bring out an 8-inch needle pointed at this dude's chest, and people are still doing CPR and shit. You're like, oh, yeah, this is fun. So, cool experience. Anyways, pericardium has 2 subdivisions, the visceral and parietal pericardium. The visceral is the part that touches the organ. Parietal is the part that doesn't. So you think that your heart is kind of, if you took a semi-deflated but still containing air balloon and set it down in there and then put it inside, your visceral side is the part that touches. Obviously there's going to be air in between, and the part on the outside is the parietal. Pericardial sac surrounds the heart. It consists of dead network of collagen fibers. This helps stabilize it in position, and it helps stabilize the great vessels that are associated with the heart. Obviously, if we did jumping jacks, we don't want our heart bouncing around inside like a bouncy ball, so this is what keeps it affixed and adhered to everything that it's supposed to. You can see that little gap right there and that little gap right there, and it's actually a small one underneath. That's where if you do a pericardial synthesis, you have to put this 10-gauge needle in there. Which, granted, it gets bigger because it fills up with blood, but still. Not cool, but not fun. The pericardial cavity is the space between the visceral and parietal surfaces, so that air gap, if you will. It contains a small quantity of pericardial fluid, which acts as a lubricant to reduce friction and friction against movement while your heart is beating.
So what was that guy doing that indicated that he needed that? What was happening to that patient? I mean, I was there, I was half trying to clean stuff up, but what happened that indicated you guys doing that procedure?
The chronic rearresting after ROSC, narrowing pulse pressures, limited pulmonary activity was just showing that blood wasn't moving very much even when we were getting ROSC. The narrowing pulse pressures and the constant ventricular rhythms into loss of ROSC were just indicative that there was that pericardium, because the heart couldn't do it. It just, you know, only being able to do so. We would get ROSC, it just wouldn't sustain because, you know, the heart isn't, you know, it's trying and it's like, I can't keep doing
So
this.
is that very similar to like type 1?
Same concept, but it's only dealing with strictly the heart. Anatomy, you have two atria, which are thin muscular walls that are in retrospect to the ventricles. When we get into cardiology, we will have either cow and or pig hearts in here. So if you don't deal with animals, you're gonna have to that day. So just let you know to either get a Xanax prescription or just get the fuck over it by the time we get to cardiology, please. Unless you're like kosher or something, then I'll get you the other one that you can. Like, I'll make that arrangement, but beyond that, you're dealing with it. It's highly expandable, deflates when not filled with blood. Deflates is a bit of a stretch. Its structural integrity slightly compromised, but it doesn't just like fall in on itself every time. Forms a lumpy wrinkled flap called the auricle, which is right up here. Where's that? Here? Yeah. And right, there's a left one over here, your right one is right here. Typically, when we deal with patients with AFib, what's happened is a clot has formed up here and affected part of the muscle tissue, because these are like, they're loose flaps, it's almost like ear, but they're hollow. And obviously when your heart beats, blood becomes kind of stagnant up there and it forms a little bitty clot and then it ends up circulating into your heart tissue. So that's typically what happens. The surface of the heart, you have the coronary sulcus, which is a deep groove filled with fat. Some amount of fat on your heart is normal. For it to be completely encapsulated, tis in fact not. It marks the border between the atria and the ventricles. You can see it wraps like this. Now, your heart, you have to remember when we're dealing with the heart doesn't lay like perfectly up and down, and it's not divided perfectly up and down. It sits kind of at an angle. So when we're dealing with these dividing lines, they're at angles. While it is straight, it's just not 90 degree, 0 degree flat plane type deal. You also have shallow depressions at the anterior intraventricular sulcus and the posterior intraventricular sulcus. This marks the boundaries between left and right ventricles, which is going to be going this way. It goes down. You have it on the front as well. So the front will be your anterior, posterior, same thing, just on the back. Contained in these sulcuses, within that fatty tissue, is a lot of the vasculature that supplies the blood flow to the heart. One of the biggest, and I don't mean any disrespect by this, a lot of people think this, the heart does not get its blood supply from the blood inside the heart. Once your blood pumps out of your heart through the aortic valve, it goes into your aorta. The aorta actually has a little tiny branch that wraps around and feeds your heart with blood. And then there's a little feed that goes right in to the top of your vena cava that returns that blood to the heart. So not only, when they say there's 2 circuits of circulation, there's really kind of 3. You've got pulmonary, systemic, and its own. So when we're dealing with this, you have vasculature of your heart as well. And that comes from the heart. So, obviously dependent on itself. The superior end of the heart is called the base of the heart. It's where the connections of the great veins and arteries connect. It's actually at the top. The base is at the top. This is one thing that gets confusing. The base of the heart is at the top. The inferior or bottom portion is called the apex, and that is where the heart comes to the point down here. So the base is up here, apex is down here. I went the wrong way, my apologies. The heart sits at an angle, as you can see here, of longitudinal axis. So when we talk about axis deviation, which again, I'm getting ahead, but when we talk about axis deviation, we're talking about how that heart is sitting on a longitudinal plane, which we can have longitudinal or latitudinal axis deviation in the heart, or in the chest wall. But when we get into there and we're talking about axis deviation, that's what we're referring to. And that can be from birth, or it can be because of a medical condition that's causing the axis deviation. It is slightly rotated to the left. The anterior surface consists of the right atrium and ventricle. So what that's saying is a lot of the right side of the heart is actually facing out, and a lot of the left side of the heart is facing back. So in theory, if we're talking about the left and right side of the heart, the front would actually be facing your left armpit a little bit. So if we're talking about the front, if we're dividing into left and right.
So is that why, like, whenever we do a 12 lead, we come down under the left breast and go over?
That has part to do with it, yeah, because what we're doing is we're getting, the further we go around this way, we're encapsulating into the left side of the heart. And again, once we get into cardiology, you'll know, we only use, during a 12 lead, how many stickers do we use? 10, right? But we have different ground points that certain leads will shoot this way, but then that other one will still be a base lead and it'll shoot this way. So that's why we get 12 readings from 10 stickers. But it has to do with certain angles of the heart, and that's why when we go to read, I think I was on a run with you the other day, that somebody had said something, I said there's massive axis deviation, so you're gonna have to either move your leads or understand that this isn't what it's showing. Mm-hmm. It all depends on what we're looking at and how it's positioned in the chest. Your heart wall consists of 3 distinct layers. Your epicardium or visceral pericardium, we will refer to it, or I will, refer to it as epicardium in here. Your myocardium and your endocardium. Which one do you think is your thickest layer?
Myo.
Your myocardium is in fact your thickest layer because it is what? What is your heart? It's a muscle. And then your endo is obviously the inside, and your epi or visceral pericardium is the outside. Epicardium covers the outer surface of the heart. It's covered in a serous membrane that consists of exposed epithelium. And there's an underlying layer of loose connective tissue that attaches itself to the myocardium. I'm sure a picture like this, similar to this, is in your book on page 4 to 62. See, this part is less dumb than the last few weeks, so it should be slightly easier to pay attention. Your myocardium is the muscular wall of the heart that consists of cardiac muscle tissue, blood vessels, and nerves. And what is important to remember about the nerves and tissue within your myocardium?
Generate their own.
It's automaticity, right? They generate their own nerve impulses. Your cardiac tissue forms concentric layers. Yeah, towards the end of class. Wraps around the atria and spirals into the walls of the ventricles. The cardiac muscle tissue is configured in a way that its squeezing and twisting motions, the way that the muscle striations are layered, help with contractions. It helps increase the efficacy and efficiency of the heart. Because if they were all striated in linear form, what would it just do? It would just kind of elongate and cinch in on itself. Your heart muscle actually runs several ways and crosses each other, so when they do constrict, it actually contorts your heart on each heartbeat, causing more power, more of a crushing response than anything.
So it's more like twisting a towel versus
Yeah,
crushing.
instead of squeezing it, you're squeezing and twisting. Who's fucking with? Your endocardium covers the heart's innermost surface and valves. It is comprised of simple squamous epithelium. How many nuclei do those contain? Huh?
One.
What are they shaped like?
They're shaped like a flat, and then
Good job. 2 stars for you today. Continuous with the endothelium is attached to the blood vessels. Your cardiac muscle is unique in and of its own sense. They are much smaller than the skeletal muscle fibers that we talked about 2 weeks ago. They contain a centrally located nucleus. They also contain myofibrils. They help with contracting that shorten the actual sarcomere, because remember we were talking about when your muscle fibers and your musculoskeletal fibers contract, what is actually happening? The inside doesn't move, and it just pulls from the ends, right? And each end starts to fight each other and it draws in. Here, the whole actual sarcomere is shrinking in and of itself, right? That's what's allowing it to cause it to shrink, twist, and squeeze. Your heart is totally dependent on aerobic metabolism, meaning what?
without oxygen.
Without that.
Oh, with that, yeah.
With oxygen, right? 'Cause it means it must have an oxygen supply. And that's why your heart can only make it very few minutes without any type of actual oxygen response to it before it freaks out and doesn't want to do anything with it. It contains many mitochondria in those sarcomeres, abundant reserves of myoglobin, which do what? Store oxygen. And their energy reserves are also stored as glycogen and lipids like the rest of your skeletal muscle. So it has the same reserve factors there. They're connected with several other cells, meaning they don't just bind one to one. These cardiac muscles actually branch out. The specialized sites are referred to as intercalated discs. It's the only spot you will see these type of connections, and their interlocking membranes are held together by desmosomes. They are linked with those gap junctions, which are what? Anybody remember? You should. What are gap junctions?
Let things through.
Huh?
Let things through.
They let things through? Like what would be super important?
Electrical.
What type of ions?
Sodium.
Sodium and potassium, because this is a actual muscle. While it is an organ, it is a muscle. And with it being a muscle, it requires what? And that action potential to continually swap back and forth, right? Desmosomes help convey the force of contraction from cell to cell. They would actually pull together during contraction. Gap junctions provide the movement of ions and smaller ions that enable the action potential to travel rapidly between cells. Why is the rapid rate important? It needs-
Like a slow cascade event.
Correct, it needs to be a very quick and concise contraction. Would it, you don't want it just doing one of these, like we're bagging a BVM, because then what's gonna happen? Blood's just gonna kind of leak out. You need it to be a very forceful and quick contraction when these muscles do contract. The heart includes a bunch of collagen and elastic fibers, mainly around your valves. It also wraps around each cardiac muscle inside. And there's actually a fibrous skeleton of the heart that is made from those collagen fibers. You can see here, these are these valves that we were talking about. And these are the coordinate tendinae that actually link and fuse to the heart muscle in the inside, and that's what allows them to stay rigid. And when the heart actually beats, is what's causing those tendons to tighten up and open those valves. Connective tissue provides support for the blood vessels, the nerves, all of that stuff. It adds strength, it helps prevent from overexpansion, and it actually helps the heart return to the normal shape after contraction. That way, that collagen, that fibrin in there helps it do its thing, but allows it to snap back into place and not become almost gelatin-like overuse. Beating 100,000 times a day, there needs to be some rigidity to it. Obviously, those connective tissues, since there is some elastic that it needs to move, but some of it is actually collagen, which doesn't, it stretches, but it doesn't stretch and stay stretched. That's what the elastic fibers are for, and allows it to return back to its shape. Again, 4 chambers, 2 atria and ventricles. The 2 atria are separated by a septum, and the 2 ventricles are separated by a septum as well. You can see the septum between the ventricles on the button is significantly wider than the ones in the atria, just due to size alone. Once we get into cardiology, you will in fact have to know all of this. Lots of signs on this side of the room. You have an atrioventricular valves. You have dose of them, which open between the atria and ventricles on the same side. Those coordinate tendineae are there, like I talked about earlier, that actually attach to that muscle, and these coordinate tendineae, once the heart relaxes, prevent the valves from flopping back up into the atria. When that happens, you have a prolapsed valve or a leaky valve, also known as what? Correct. A heart murmur is actually the valves not constricting all the blood to its designated chamber. Your right atrium, again, receives blood from systemic circulation from the inferior and superior vena cava. You can see inferior, superior. It's a lot of information for about 10 seconds of talking. And when we're talking about superior or inferior, your superior vena cava is going to be anything above the heart. Your superior vena cava is going to be anything below the heart. You just skip straight to veins, huh? Cardiac veins return blood from, or to the coronary sinus from the heart muscle, and they also open and dump into the right atrium. You can see, it should be right here, that it dumps into the right atrium. It connects where the superior and inferior vena cava meet. Right below that is their connection for the actual circumflex. So if we're dealing with the heart, and I'm going to give more of a front, and I'm not a fucking Picasso, so deal with it. Okay, so when we're dealing with this, we have, what would that be? Inferior. And then you have right? And you have to remember, whilst the ventricle is on the bottom of the heart, it actually, the connection is actually the backside of the heart that causes the aorta to shoot up, okay? So there's not a fucking pipe down here that just comes out the bottom of the heart. This is not a gravity-fed process. So it's up here, and this is our aorta, right? What happens is on this side, you have these veins, and this is your circumflex that wraps around, right? They branch off. Here, right? Your aorta actually wraps around and dumps in, and it mimics all of these channels, right? And does that. Just drop obviously, there's a lot more than that, but this is just your great ones that we deal with on our end of things. So, when we're dealing with certain illnesses, issues, or MIs, we're dealing with the location, right? So, we all have to remember, and again, I go a little ahead here just so you can understand what we're dealing with. When we're dealing with certain issues, when we hear I'm gonna draw this. So this orange is going to be nervous tissue. And we have to remember that there are actually two different systems that are happening here. You have the electrical system, right? And you have the circulatory system. The problem is they're dependent on each other. So when we deal with MIs, what are we dealing with from our end of things?
Circulatory problem?
It's a blood flow issue, right? But is the blood flow the complete? I'll turn this on because you guys probably can't see. Oh, wrong fucking one. You see now? We are trying to fix the circulatory problem. Why? Huh?
So it doesn't die.
Right, because what happens when the tissue dies?
It's dead.
And what can't it do at that point? It can't, that part where those nerve fibers end will not contract anymore. They'll just sit there and they're just along for the ride with its neighbors, right? But what happens when that continues to spread? More muscle death happens and less constriction happens because there is none of that automaticity, right? So if we only have the top of the heart pumping, is that doing anything? No, your chamber's gonna fill up, they're gonna start leaking and you're gonna die, right? So that's what we're dealing with. And we have to remember, and this is the confusing part for a lot of people, when we're looking at an EKG, what are we looking at? The electrical activity, right? But what is that showing me? While I'm looking at the electrical activity, what is it telling me about that heart? How it's being perfused, right? We control the blood flow issue, we treat the blood flow issue to save the electrical issue. That's what we're trying to do. So when we're looking at an EKG and we see something like this, in V3, right? Which again, you might know what that means. If I'm looking at something like that, what do I have there? Again, I'm not an artist. That's a major ST elevation, right? Now, I know where lead 3 has to deal with, right? And that has to deal with a certain part of the heart. Because each lead, when we're dealing with 12 leads, we've got 1, 2, 3, stupid lead. Okay, we deal with that, right? And we know that each one of these is looking at a different view of the heart, right? So I know that V3, in this case, is an anterior lead. What does anterior mean? The front, right? So I know that V4 is also an anterior lead, right? Lateral. So if I'm dealing here, right? I'm dealing with this anterior lead. That's going to mean it's what part of the heart? Front part of the heart, right? So when I'm dealing with the front part of the heart, I mean the front part of the heart, not the right side of the heart. Because where is V4 going to be on my chest? Right about here, right? And it's taking this lead up here as its base lead, so it's shooting back this way. So it's actually taking this picture of the heart, not the picture of the heart sitting sideways in your chest. So we're dealing with the front part of the heart. And what lies in the front part of the heart? Anybody know what that's called?
Paramedic.
A widowmaker. So again, while that's showing me the electrical activity of the heart, it's because I have a clot in the circulatory part of the heart. So we're monitoring all of the circulation off of electrical impulse. That's the biggest thing that you guys need to wrap your head around right now, is while we are viewing the electrical activity, it's telling me how the circulation, perfusion, and oxygenation or deoxygenation is occurring in the heart. Good? Okay. That's dumb. The foramen oval is an oval opening that penetrates the intraatrial septum until birth. So you actually have a hole in your heart between the two atriums at birth. This allows blood flow between the atria while the lungs are developing. Why is that important? Let's think about it. We just went over the drop of blood. If I'm a little baby inside mommy's belly, or I'm with the stork, what am I not doing?
Breathing.
And if I'm not breathing,
Nothing's circulating.
Oxygen's not circulating through the blood.
you're getting oxygen from where?
From mom.
Mom, right? Moms are going to perfuse the oxygen. But what does mom perfuse first? Herself or the baby? Anybody know?
So,
Herself. So her free radical oxygen in her systemic circulation for the baby is limited, right? And with the baby not perfusing, that oxygen is very limited. And it has nothing to pick up because air's not coming in. So what does it do? There's a hole between the atria that takes the oxygenated blood from the mother, sends it from the right atria as it beats right over to the left atria, and then down the left ventricle into the baby's systemic circulation, because there is no oxygen in the lungs for it to pick up, because it's not what? Moving air. So there's nothing for it to pick up. So that hole is very important. Problem is, for some people, that hole never closes. And that gives you a birth defect. Now, it's a very simple procedure nowadays for them to fix, but it can happen. Usually within 24 to 72 hours, I say around 48 hours is normal time, but 24 to 72 hours, that hole will fix itself, and it's not like it's a fucking golf ball, it's very small, right? But that hole will close up and it won't be another issue. But some people do have that birth defect, some choose to get it fixed, some do not, some people have to or they'll die depending on the size of the hole. But that is one thing to consider, especially if you're ever dealing with a newborn child, thinking about systemic circulation and medication administration that may not always work how you expect.
What are they doing in the hospital to determine if that, when and if that closes?
So they look at, so the big thing is honestly their vitals and their oxygen readings and their blood pressures, because their blood pressures are dog water when they're first born, and they make sure, obviously the more that closes, the better that pulse pressures get from each other, because the pulse pressures are the difference between what? Diastolic and systolic pressures, right? So if I've got 120 over 80, what's my pulse pressure? 40. It's 120, it's your systolic minus your diastolic, right? So my pulse pressures are 80. Typically when babies are born, you'll see like 70s over 55s or 60s. Those pulse pressures are super close because why? When their heart's beating, they don't have the same pressure between chambers because it's leaking over into the other. As long as they see a widening of those pulse pressures, it's probably indicative that it's there. The oxygen helps actually that tissue gain and start closing up pretty quickly because it helps that tissue growth. Sometimes if they're concerned, you can hear it because you'll hear a murmur sound, and if that murmur doesn't go away when they listen to the heart, they'll be like, hey, you know, this is still here, so something we may need to address, then they'll do chest CTs and all that kind of stuff. It may remain opening after birth, allows the left atrium to push blood back into the, after birth. The reason that it's going to push from left to right, because while it's in the baby, it's pushing what? Or while it's in the mother, it's pushing what? Right to left, right? Because their heart's only doing so much. After they're born, it pushes left to right. Why? Now, that part of the heart is significantly bigger than the right, and that's just a pressure change. That's just gradient. That's all that is. It's going to push backwards. And that can lead to an enlarged heart. If it's not fixed, that's going to lead to heart failure And then obviously heart failure is going to lead to death. You want to do those forms ready? For what side? Oh. Yeah, I'm a teacher.
Where are those forms?
Yep.
Yeah. I already
Here
have.
somewhere.
Huh?
Am I the training institute
Yeah,
official?
because I can't be the official and sign up my own PI, so. Because she didn't know where they're at. You know where they're at.
Back here probably, in the, one of the cell file cabinets is back there.
You see them back there, back there.
You can send them in first. Your right atrioventricular valve has 3 flaps or cusp. That's why they call it the tricuspid valve. Tri meaning what? Right there it is. Surrounds the broad opening between the right atrium and ventricle. Your bicuspid or mitral has what? 2. Those coordinate tendonae are the connective fibers that help connect the flap to the heart wall. That way it doesn't transpose itself and prolapse. Keeps it from flapping back on itself. And when the heart contracts, it allows the blood to go down. And when it relaxes, they close back up to normal, but they don't flap back up into the atrium. Your papillary muscles are cone-shaped projections. They're located in the inner surface of the ventricles. They're down here. And you'll actually see when we dissect that heart, you'll actually see they do stick up. They're like stalactites and stalagmites inside a heart. It's just muscle tissue that's kind of thin and fibrous, stretches up for a lot of things to connect to. And you'll get these valleys and holes. It's not like coral reef where these valleys continue into the next one. They're just pockets where those muscle striations have formed almost a belly in there. Your papillary muscle contractions tense the coordinate tendonae and limit the movement of the cusps. And that helps prevent the backflow. That's so you don't get that regurgitation of blood back into the atria from the ventricles. Those coordinate tendonae you can see are attached here. They'll limit them up. And then again, when the atrium beat, they just open because there's no resistance on them. There's resistance up because those coordinate tendonae, it's kind of like holding it down. You know, if I'm holding the board with a stick, someone drops water down, it's going to come down fine, right? But then I'm going to snap it back up just so it doesn't go anywhere. It's essentially what they're doing. It's just reverse pressure. Blood flow from the right ventricle flows. We already went over that. I'm not going over the flow. We already went over that through that. Oxygenated blood, left atrium, left ventricle. There's probably something important in those. The left atrioventricular valve contains 2 cusps, the bicuspid or mitral. Like I said, I will refer to it as the mitral valve. The left ventricle resembles the right, except it's on the left, and it's significantly larger. Also has pairs of papillary muscles that branch to its coordinate tendonae for its mitral valve. And the blood pressure goes through the aortic valve. Your pulmonary and aortic valve are just, we'll make 20 copies of that or whatever, are both semi-lunar valves. Your pulmonary and aortic valve are semi-lunar valves. I'm going to tell you this next test that's coming up, I'm going to hit very, very, very hard on the heart, the lungs, circulation, blood vessels, and all of that before I hit on all the other stuff. Just letting you know.
Heart, lung, circulation, and what was the other thing?
Blood vessels. And I think there's one more actually. Probably the digestive system as well.
So we're safe not to know the recessive traits for color blindness and stuff?
Yeah, you're okay. Both atria collect blood returning to the heart from systemic and pulmonary circulation. They will obviously dump blood into the ventricle. The demands of the ventricle can be different, but they're going to pump at the same rate. right ventricle, lungs are close to the heart, thank you. Pulmonary veins are short, they do not require as much force to propel through the pulmonary circuit. Why? It's close, and there's not a whole lot of resistance, right? Your muscles are, or your lungs are very expansive, there's not gonna be a whole lot of resistance, and we're talking about inches and not feet going down to my toes. Structural differences between the right and left. Right is a relatively thin wall, myocardial layer, compared to the left. You can see the differences between here and here. It's almost like the right ventricle was an afterthought. We built this all big and cool and like, fuck, we need another one. We only have limited supplies, so let's just attach this on there. The right ventricle, the contraction squeezes the blood against the left ventricle. So that septum, that ventricular septum, when the blood squeezes, it comes in and uses the muscle tone of this wall to squeeze against. And then obviously that's going to go through the pulmonary valve. Your left ventricle requires 6 to 7 times more force and effort to propel through the systemic circulation. Why?
It has to pump further and.
There's miles of vasculature on the systemic side. Obviously with that, it's extremely muscular compared to the right side. What fun fact did you Google?
Oh, no, sorry. They just finally announced our new chief.
You getting the new one? Who is it?
He's the Anchorage Training Division chief right
Mark
They didn't.
Coleman.
Who?
Mark Coleman.
They didn't hire internally?
I don't know.
Why?
I don't know if it is. I was shocked. I figured they would hire him.
Who we put in for it internally?
Joey and Tony.
And they didn't hire either of them? No. That's a bad precedent to set. Okay, moving on. The distance between the apex and the base of the heart decreases when the heart, obviously with that squeezing and twisting motion, with it twisting, it's actually going to shorten the elongation of the heart while that happens. So the apex and the base come closer together. The diameter of the ventricular chamber obviously is going to decrease because it's squeezing inward. And with that left ventricular contraction, because it's using the septal wall and the left ventricle, it actually causes that septal wall to bulge out into the right ventricle a little bit, and then it also helps propel blood out of the right ventricle. Again, you have atrioventricular valves, which are what?
The valves that connect the atrium to the ventricle.
Which are what? They have names?
Mitral and tricuspid.
The tricuspid and the mitral or bicuspid, and your semilunar valves, which are what?
Pulmonary and aortic.
Okay. Again, your the atrioventricular prevent backflow from blood from the ventricles into the atria at rest. Those coordinate tendonae are loose, and the atrioventricular valve offers no resistance to blood flow from the atrium to the ventricle, so it'll go in as it needed. When the left ventricle contracts, those muscles tighten up, they pull it up and in, and that keeps it from backflowing up into the atrium. With ventricular contraction, blood moves back towards the atrium. That forces those cusps closer together, and once those cusps will come up, those coordinate tendonae have enough resistance on it that it will not allow blood back into the atrium, and then forces it out its respective semilunar valve. Tension in the papillary muscles and coordinate tendonae keep those cusps closed like the 13th time, and that prevents that regurgitation. Regurgitation may occur in small amounts and it's normal. I mean, it's just a pressure thing. You know, you put too much pressure on the hose, it's gonna leak somewhere a little bit. It's gonna be dependent on your blood pressure and your heart rate and all of that, how much regurgitation there might be. When there is that regurgitation and going through those valves, where those valves are kind of double layered, that's what creates that heart murmur sound, is that swooshing of the blood going through there. That is what you'll hear. So when you hear that murmur, you're hearing that blood leaking through the valve into the atrium. Somebody here has one. I'll let you listen to it when we get to cardiology. Somebody here's a heart murmur, you can like hear it. Semilunar valves prevent backflow of blood from the pulmonary trunk and aorta. Does not require muscular bracing. The arterial walls do not contract, and they're just there. They don't have the same coordinate tendon to keep them shut. It's just kind of like a one-way valve, if you will. Semilunar valves closing have 3 symmetrical cusps that support each other, and they prevent the backflow of blood. They pretty much, without locking, they interlock into place where they can't extend, and then they open and they close back. They don't have those papillary muscles and loose coordinate tendinae sitting there attaching everywhere to keep that from happening. Your aortic sinuses are sac-like expansions at the base of the ascending aorta. They're found next to each cusp. They prevent the cusp from sticking to the wall of the aorta when opening. The origin for the right and left coronary sinuses. So this, aortic sinuses, is where the right and left coronary arteries start. So that is where the blood flow to the heart and from the heart start at, is the aortic sinuses. See it right up chill. The blood supplies to the heart, by the heart. So in case we didn't cover that already. There you go. Right and left coronary arteries originate at the base of the aorta, at the aortic sinuses, like we just discovered fucking 2 slides ago that we haven't repeated now because we already forgot. This is the highest blood pressure of the systemic circuit. This is where max, think of it as muzzle velocity. This is where it will be the most, right? Why? Because it's the shortest distance from the source of the pump. The further you go, the less pressure you get. And if you didn't know, the coronary arteries start at the aortic sinuses. I don't know if we've covered that or not. Your right coronary artery supplies blood to the right atrium. You need to know this stuff, so write it down, highlight it, circle it, watch it. Doesn't matter, know it. The right coronary artery, the RCA, supplies blood to the right atrium. While it does supply blood to both the portion of the both ventricles, it is mainly on the right side. You can see it. Where is it at? I'm trying to figure out the fucking view here. Why is it not on? Right here. So you're going to see, comes around the circumflex, backs off, and it dabbles down into the bottom of the apex here. Your left coronary artery supplies blood to the left ventricle and the interventricular septum, the really, really important part of the heart. Like, gotta have it, no death here or you die here type thing. This is the LCA. Some of these are going to have different names. This left coronary artery can also be a left anterior descending artery. This is, it's going to be cardiologist to cardiologist, book to book, teacher to teacher. That can vary. Your left coronary artery, your left anterior descending, all of those, your left circumflex, your right circumflex, while they're all important, that anterior descending or that left coronary artery are hyper important. If not, you don't have systemic circulation. There's two branches of the right coronary artery, the marginal and the posterior. And you have two branches of the left coronary artery, the circumflex and the anterior or descending branch. So you have the left circumflex and the left anterior descending or the left coronary artery, whatever you want to call it. That word, anastomosis, whatever, are interconnections between the small tributaries from the branches of the left and right coronary arteries that dump down, or where they'll dump down into the other pathways. Again, these create alternate pathways for blood supply. So, you have coverage from all of these vessels. So if there is an issue, it's not like there's instant death, but if it's not corrected, it can't sustain. Because it's like, am I gonna put a fire out with the 2.5 of this garden hose? Will I get some water on with a garden hose? Absolutely. Am I gonna fight the fire and knock it down with it? No. So you have these internodal pathways, or the intertertiary pathways that can help supply these areas of the heart with alternate blood supply, but they cannot sustain for long periods of time. You have your great and middle cardiac veins that carry blood away from the coronary capillaries that drain into the coronary sinus up at the right atrium. Your coronary sinuses are large, thin-walled veins located on the posterior portion of that coronary sulcus. Again, those dump into the right atrium. Right there. An infarct is an area of dead tissue caused by an interruption of blood flow to that area.
So it's just dead, not damaged? So it's just, if it's that, it's dead, not damaged?
And we'll get to that point, yeah. An infarction is caused when coronary circulation becomes blocked and those cardiac muscles start to die due to lack of oxygen. Most of them are due to coronary artery disease, which is pretty much atherosclerosis of the coronary arteries. So how you can get that systemic circulation you have high cholesterol and all that good jazz, you can get that in your coronary arteries as well. The heartbeat. Your atria and ventricles are obviously have to be in a coordinated manner, because if not, that would cause problems. You have two types of cardiac muscles: contractile and non-contractile. Contractile obviously produce the contractions that propel blood. And your non-contractile are the part of the conducting system that control and coordinate how that electrical activity is dispersed through those muscles. Again, blood flow and electrical activity work hand in hand. Mechanical versus electrical. You're going to hear those two terms, mechanical and electrical, for the rest of this class. We monitor the electrical to know how to fix the mechanical. The contractile cell form the bulk of the heart's muscle tissue. That has the same method of using calcium among those myofibrils that bind to troponin and thin filaments, and that contraction begins. Same concept of how it does, but with the intercalated discs and the way that the whole muscle tissue shrinks, while the process is the same, the actual muscle contraction is different. But it still uses calcium, still uses troponin, still uses ATP, all that stuff still works the same. Contractile cells, differences between those muscles is the duration of action potential, dependent on the source of calcium, and the duration of the contraction. You can see with our cardiac muscle being in red and our blue being in the action potential versus contraction, action potential versus traction. Here's your skeletal muscle, here's your cardiac muscle, right? A lot more action potential is needed here, significantly amount more. But look at the contraction difference as well versus the two. The action potential starts in the ventricular muscle cells, begins when the membrane is brought to threshold. Remember, we were talking about the amount of movement, and the threshold is what? When we're talking about threshold, what is threshold? It's once it hits that threshold, there is no stopping that contraction, right? If we have something that there's some action potential there, but it doesn't reach threshold, what happens? A twitch, or it doesn't conduct, right? Now, who's been in here the least amount of time? And I don't mean this in a disrespectful way. I'm meaning this, and you probably have this, how long have you been in EMS?
2.5 years.
Anybody less than 2.5 years? Okay. Okay, never mind. Who's been in here more than 5-6 years? Okay, I'm sure all of you, and I'm sure you guys have as well. And the only reason I say this is just because of the time of exposure and being with medics. You've seen things, PVCs and PACs on EKGs, I assume, heard the term PAC, premature atrial complex and a PVC, right? So when we're talking about those things, obviously a heartbeat, this right here, this is one heartbeat, right? This right here, right? When we're dealing with this is a conductive beat, right? The muscle contracts and the electrical activity passes through it. When we're talking about something that doesn't reach the threshold, is something that we can see on the monitor. Again, this is a mechanical portion because it's saying, hey, the heart's working here, but it is shown on the monitor as a PAC because you have an initial muscle twitch, but there's not enough threshold met there to conduct the full beat. Does that make sense? So we've all seen, when we're looking at a normal EKG, here's an eraser. So here's our, okay, that's a normal beat, right? And we have this times a lot. But sometimes we'll just see one of these like, hey, right? This right here is a PAC. What that's saying is I had an electrical impulse, but it didn't reach enough action potential for me to conduct anything. So again, the mechanical part is being showed through the electrical activity. Same concept for this. If you don't get that enough stimulus to reach that threshold, there is no conducted beat. Or what happens when we see PEA on the monitor? Everybody knows what PEA is, right? It can look exactly like that, right? But there is no what? Meaning there's no what side of it? Huh?
It's not pumping blood.
But we see electrical activity, but there's no mechanical activity, right? There's electrical impulses, it's showing that there's activity, but that's not being conducted. So that's why when we all do something that I guarantee you, every one of you, myself included, is awful about doing, is when we put our patient on the monitor, we just put a pulse ox on and it gives us our heart rate in the top left corner, right? If you're dealing with a life pack, or the bottom, if you're dealing with a Zoll, right? Or we'll put them on a 4 lead or a 12 lead and it'll sit there and show, hey, bloop, 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 heart rate's 80. How many of you go like this to confirm that electrical and mechanical conduction are the same? 0 of you. And that's something that all of you need to get in the habit of doing. It doesn't have to be the entire time, right? But you need to show, hey, for this 6 to 8 seconds, every one of these beats that's going on the monitor is in fact conducting. Because that is going to be the difference. While there may be enough electrical activity there, there may not be enough electrical activity to conduct the actual beat. So that is something that all of you, as you progress, starting today, should start doing when you go to use a pulse ox or a 4 lead, is to make sure that my 80 is matching 80, or my electrical activity on my monitor is in fact conducting each time that it is. That way you know that there's not any invariances with the threshold from mechanical to electrical threshold. But you have rapid depolarization that starts the heartbeat. So, I need to go back here. Crash course EKGs. Try to make this one bigger. You can do it like this, or we can do it like this. I'm gonna switch it to this one. Okay. So, anybody know what this is called? E-wave, right? Anybody know what this is called? What is that called? T-wave, right? So those are the important parts of a heartbeat. You have anything else, probably not good. So, rapid depolarization. At threshold, sodium channels open up. Influx of sodium depolarizes the muscle. The sodium channels close when that action potential reaches positive 30 millivolts. Rapid depolarization. First part of the heartbeat. What do we think rapid depolarization shows? Back here, what do we think that is exemplified? Which one?
The P wave.
P wave. P wave equals atrial depolarization. okay? Atrial depolarization is represented as a P wave on your monitor. So you initially get that sodium channel and calcium channel influx, one rush in, one rush out. You get that initial contraction in your P wave, right?
It's also is it also showing the beginning of electrical activity in the SA node?
That's where it's originating from, yes.
So it's the same thing?
No. Yes and no. It's showing that the heartbeat, if there is a P wave, it is showing that the electrical heartbeat is starting at the SA node. Yes, that's the origination of the electrical impulse, because you have to have a P wave for that, which we'll get into later. So your initial P wave is atrial depolarization. Your plateau is not going to be shown on your EKG because we're dealing with contractile cells here, but your rapid depolarization of your atria is going to be your P wave, and your rapid depolarization of your ventricles will be what? Your QRS. That is the depolarization of your ventricles. It's actually your RS, is your depolarization. But on the contractile side, you have the plateau. And that was going back to here. So this is your initial, this is your plateau here, right? We're like, hey, we're staying about the same. So that is your plateau. The cell begins to pump the sodium out. The calcium channels open up. Those extracellular calcium ions enter back in to the muscle, and they remain open for a hot second, well, hot millisecond. And that that calcium and that sodium begin to equalize back out. Remember, we had a huge excretion, and then we do 3-2, 3-2 type deal. We're going to balance back out. That's when we hit that plateau, because everything is going back to what it's trying to fix. The functions of the calcium are to delay repolarization. Why would that be important?
To allow blood time to get into the chambers.
To allow that electrical activity to conduct to that heart muscle and squeeze all the way down. Because if it's too quick, what is it? If it just hit and repolarized, what would happen? Would you get the full efficacy of that heart muscle?
No.
Right? If I just go up and give them a hug like this, right? That's essentially what would happen instead of giving them a big old bear hug. Same thing. If there's not enough time, if it doesn't delay that depolarization, it's going to that repolarization, it's just going to depolarize and repolarize, and it's going to be ready for the next beat. What do you think we get when that happens? A really bad time. But the calcium delays that repolarization, and it keeps that potential near zero, which is, so do we remember what negative millivolt skeletal muscles usually started at?
-70?
Negatives 80 to 70, right? Mm-hmm. Cardiac muscle starts around -90. So that transition of plateauing around zero is still a huge positive change from where it started. That initial contraction triggers the release of calcium reserves and continues to allow those muscles to cinch all the way down. Again, those calcium delay that repolarization and allow that calcium to fully take place and squeeze all the way down as far as it can to continue that contraction of that muscle all the way down. Make sense? Then we go to repolarization. Calcium closes, potassium opens up, or the channels open up, and potassium boot scoots out of the cell. Because remember, where is the calcium adhering to? When we're dealing, because I know we're talking about the movement of sodium, potassium in and out, right? Where is the calcium taking place at? Where's the calcium come into play? That's what moves the troponin off of those muscles to do that, right? So that's why the calcium is important. It's not causing the swift shift back and forth. The calcium is moving those troponin for that muscle contraction to take place. So the repolarization is when those calcium channels close, potassium channels open, potassium gets out of the cell, and we restore back to our resting potential, which would be this right here on the EKG, that downtime. Because now we're ready for another one, right? So, back to what we're seeing, your P wave is your atrial depolarization. Your QRS is atrial repolarization. And also what?
Ventricular depolarization.
And why do we think we don't see, sometimes you'll see a little like,
Hey, guys.
right? You'll see that little boop going down, and then you see a big ass QRS. Why is that atrial repolarization so small? What is the size difference and muscle difference between atria and ventricle? It's massive compared to the atrials, right? So you're going to have this little fucking boop of atrial repolarization, but at the same time, your ventricles are depolarizing, and what's going to carry more electricity? Your ventricles, right? So you see that prominent QRS. And then what do we think that T wave represents?
Repolarization of the ventricles.
Your T wave is ventricular repolarization. Now think about that for a second. What do we think? I mean, not what do we think. Well, in reference to cardiology, what is one of the most critical runs we can have? Also known as a STEMI, right? Because what's the difference between a STEMI and a non-STEMI?
One has damage and one's has potential.
False.
One you can see on the EKG and one.
What?
You can see one and the other one you can't.
One you can see on a monitor and the other you cannot. That's the difference.
That happened to us.
And the problem is, most places downplay non-STEMIs. Just because there's not elevation doesn't mean that there's not dying tissue. The difference is, I know where the fucking problem's at with a STEMI versus a non-STEMI when I don't. So if we're thinking about what we just talked about, calcium, potassium, and sodium, right? And we're thinking about what happens here. If I'm dealing with what do we think is happening here? Let's think about what we just talked about. Look at what a normal EKG is supposed to represent, and look at what's happening when I'm having a STEMI.
It affects the repolarization?
Huh?
It affects the repolarization?
And then why, right, but why is my repolarization delayed?
Because the, it doesn't allow all the,
You don't have the ion shift between them because what's happening to the muscle?
And tissue.
It's dying. That's why we can see that. Now, the good thing for us is, with a STEMI, as opposed to a non-STEMI, I've got 12 leads to look in to see where that STEMI is at. And I know I've got certain medications that I would say, in this type of STEMI, I need to do this, and this type of STEMI, definitely don't want to do that, and I need to do certain things to help with this heart tissue. That's why it's important for us to understand what's going on electrical and mechanical, again, at the same time. Does all of this make sense? At a very microscopic level. Do we understand what's going on with the contractile part in reference to the electrical part? I understand you have to separate the two, mechanical versus electrical, but they also have to go hand in hand, and you have to understand what's going on while one's doing the other. Again, here's your phases. Rapid depolarization. What causes it? Sodium enters the cell. A shit ton of it. Right? Sodium enters the cell at a really fast rate, causes this huge spike. At the plateau, all that calcium rushes in, moves that troponin off of the filament sites, allows that contraction to happen. The calcium releases, you lose a bunch of potassium, and it equals back out. Now this right here, during this muscle contraction, is called the refractory period. What cannot happen during that time? Right? Any electrical impulse can be sent there, but that doesn't mean anything's going to happen. And that's why it is important to confirm mechanical versus electrical. Because if it's showing electrical, right, that'd be like every code that I've ever worked, throwing a patient on the monitor, seeing PEA and going, they're fine. Because my monitor says they have a heartbeat. But I haven't confirmed that the mechanical and the electrical match each other. Because with some of these people, especially AFib RVR is a huge one, where you're going to see a shit ton of electrical activity, but you're not going to have the mechanical activity to go along with it. So that's why it's important to understand what is going on. Now, if you have a person that is going to have a really high heart rate, fast heart rate, right? What causes a quick polarization? What is going to cause a quick repolarization? A shorter what? When does the refractory period take place during? The plateau. And what do you need for there to be a plateau?
Rapid depolarization.
No, what ion do you need for there to be?
Calcium?
Okay. So if I have a shorter plateau, what am I going to think about my patient? They're probably low on what?
Calcium.
And what can I give them to slow that heart rate down? It's fucking crazy how that works. Right? These are all things, that's what I'm saying. We're getting ahead into cardiology. We need to understand the A&P side of it, which I think is beneficial to see them work together. So if I've got a patient that I've given certain medical, now granted, calcium is not going to be the first route, but if I've given them things like cardizem, or I've given amiodarone, or I've given even adenosine, right? And it's not working because some of them aren't going to work depending on the ionization in the heart. I know, hey, my normal routes of cardizem didn't work. My normal routes of amio didn't work. What is a backup gray area where I live can I do to kind of help this? I know, hey, maybe I need to try some calcium. Maybe I can cause longer plateau times to slow that heart rate down. These are all things that we need to start focusing on and understanding what's going on with this versus what's going on with this. Action potential, we pounded in the ground. Depolarization, we pounded in the ground. Refractory period, we know we can't do anything else when it's happening. Cardiac muscle and tissue contract on its own, referred to as automaticity. If you don't already know that word, you should. And if you don't, learn it. Each contraction should follow a precise sequence. Obviously, atria work first, and then the ventricles. If not, what happens, do we think? Any idea?
SVT?
Not particularly. You got the VT part, right? Correct. Because what happens? Your ventricles are pretty much, anybody heard the term runaway diesel? That term, if you're in cars, where diesel motor, you can't shut it off, you turn the key off, take it out, throw it in the river, and the thing's still running. That's essentially what happens to your heart. That's essentially what happens to your heart. The bottom takes over, it's no longer regulated by the SA node or the top part of the heart, and it just starts fucking doing its own thing. And then that turns into that, which turns into the one that's behind the thing, which is just a flat line. Initiate and distribute electrical impulses. You have two types of cells that do not contract, nodal cells and conducting cells. So again, with the contracting part, we're talking about what side, electrical or mechanical? Mechanical. So now we're going to talk about the electrical side, nodal and conducting cells. Nodal cells are responsible for establishing the rate of cardiac contraction. And you have two nodal cells. You have your SA, or your sinoatrial node, and your AV, your atrioventricular node. Those are known as the two main pacemakers of the heart. The primary one being the SA node, which lies in the right ventricle, demonstrated by my top orange dot on my masterpiece back here. So as you can see, this, sorry about the peeper in your face, is your SA node right here. That is the main pacemaker of the heart. Anybody know what the rate of that is?
600.
60
40 to 6.
60 to 100. Then you can see there's a couple other pathways. Again, this is artistic purposes. You've got a couple other pathways that lead down to the AV, which is that other big node down there, right? That's this one. This is known as the secondary pacemaker. Anybody know what that rate is?
40 to 60.
Yeah, whoever. 60 to 80. So your AV node, still completely viable with life, right? Just at a little bit slower rate. Now, I said earlier that in order for there to be a P wave, your impulse has to start where? At your SA node. Now, for there to be a P wave, this right here, does anybody know what this is called? Sinus rhythm. Okay? And what is the first part of SA?
Sino.
That's what that would mean. For there to be a P wave, there has to be firing at the sinoatrial node. Okay? So, if you have a sinus rhythm, that means it's originating from the SA node. Now, we've all heard the term sinus brady and sinus tach, right? Well, my rate's 60 to 80, or 60 to 100 at this place, right? How can I have 40 or 100 or 140? Anybody know? You have excitability of those nodal cells. It's still firing from there. It's just those nodal cells are hyper or hyposensitized, meaning we're firing really high, we're firing really low, or we're normalized. Still originating in the same spot, there's just the electrical, nutrient electrolyte imbalance in that area, exciting or lowering the threshold of that rate. Then you have the AV node at 60 to 80. What might be a rhythm that I'm in there? AFib. You don't have P waves, but we have a relatively normal heart rate. I have a QRS, I have a T wave, I just have no P wave. I'm going to be originating from either one of two places. The AV node, which is primary, or any ectopic, meaning any ectopic beat or cell that conducts through that pathway that is below the SA node. So if I have this SA node here, and I draw a line like this, right? I can have it beat from here as long as it's close enough to this pathway to conduct to the AV node. The higher up that ectopic beat might be, typically the higher my rate's going to be because it's closer to that SA node. But, so you're gonna have AFib is going to originate at the AV node or any ectopic area below the SA node. Then you have conducting cells. They are what help distribute the stimulus that is sent from the SA or the AV node to the rest of the myocardial tissue. Those major locations are the AV bundle, also known as what? The bundle of His, the bundle branches, and the Purkinje fibers. So, I've already got it up here for you because I'm a master artist. So my bundle of His is this group of a bunch of pathways that is going to be just below the AV node. This is where all that information is gathered and it is sent out to the ventricles, right? Anybody know what my rate there would be?
40 to 60.
There it is. 40 to 60. Then I have my bundle branches that come down into the right and the left side of the heart respectively. They're the big horseshoes that loop. And then I have these little fingertips that spread out from those bundles called the Purkinje fibers. The Purkinje fibers are like the capillaries of the electrical system. Very small pathways that help just distribute a little bit of that electricity. Anybody know what the rate at the Purkinjes would be?
20 to 40?
Or not Purkinjes, the bundle, sorry.
Bundle,
Where they have
that was
bundle
40 to
of
60.
No, the bundle of His. The bundle branches and Purkinjes.
Oh,
Where they have 20 to 40.
30 to 40. Anything under 30 is not considered viable with circulation or both. Your book might say 20, I'm just telling you, if their heart rate is 22, they're dead. So, those are all the respective ones. If you have an electrical impulse coming from the Purkinjes, your rate's probably going to be in the 20s, but it's not conducting anything. What that means is just extra flicker that's left in the cardiac tissue around it. It's just trying to do something to conduct something. Okay.
Yeah,
Do you have a question?
no, I had a lady last shift that had that
Had what?
Had a-
Purkinje impulse?
34 pulse rate.
They're not great and they don't sustain very long, and those people are definitely going to catch a pacer. For sure.
She was 98. We didn't know.
Oh yeah, she gonna just die at the hospital. It's true.
I can't form it.
I mean, with the way doctors are now, they probably want the money, so they'll take the $40,000, let them die on the table, or make it on a
She
surgery.
had a DNR, so we just. Thanks, Grandma.
But yeah, anybody that's gonna operate below that AV is at some point gonna catch a pacer, because your body can't sustain with that heart rate and that oxygen delivery. Nodal cells depolarize spontaneously. They generate action potential at regular intervals. And they're electrically coupled with those conducting cells. So the impulse has to start at the nodal cells, right, at the AV or the SA, and it's sent down those conducting cells. And that's what helps disperse that energy to the rest of the heart. Again, your nodal cells determine heart rate. Anything that actually originates at the nodal cells should result in a coordinated contraction. Now, going back to this a second, because we're going to we'll stop there. Going back to this diagram and all this shit a second, this is probably going to be out of the realm of understanding right now, which is fine, we haven't got there yet. Right? We've all seen something similar, I don't say we all. At some point in your career, if you stick with this, you're going to see something like this or it flipped up on the monitor. Anybody know what that's called? A bundle branch block. Now, you can only diagnose those in certain leads, so if you see it on lead 2, you can't go bundle branch. You can suspect, but again, for everybody that doesn't know, 4 leads are non-diagnostic. You cannot diagnose dog shit off a 4 lead unless it's underlying rhythm. That's as far as you got. What's their underlying rhythm? Sinus. Beyond that, you can't diagnose anything. So, you need a 12 lead to diagnose bundle branches. But what do we think is happening here? What does this represent? The QRS represents what? Right? And our bundle branches go where? Through the bottom of the ventricles, right? So if we have a bundle branch block that says, hey, that part of tissue is dead, what happens? My electrical impulse goes as normal, gets down to that area and goes, what? I gotta find another way around it, right? So that is this delay. And it goes, uh-oh. And then it finds another way around it and continues on as normal. That's what you're going to see in reference to a bundle branch block. It's that delay in it conducting all the way through that ventricular tissue. Okay, SA node referred to as the cardiac pacemaker. It's tissue mass embedded in the wall of the right atrium near the entrance of the superior vena cava. It's relatively far up top. It is important that it's on top because it's then the most surface area for that right atrium to contract because of the electrical impulse going through it. It depolarizes rapidly and spontaneously. Your book, or this book, apparently says 78 potentials per minute. Anywhere between 60 and 100 is normal. Obviously, the closer to 60 or the closer to 100, the more out of normal relatively you are. But, like my resting heart rate, because I'm fat and unhealthy, is 103. While someone who does stuff all the time is probably 62, right? It's just the term normal is relative to your patient, first off. But anywhere within that threshold is normal. Your SA node distribution for stimulus of contraction, the atria must contract together before the ventricles, and the ventricles contract together. Begins at that apex, spreading towards the base, and pushes the blood into the aorta. So, when you're seeing this, while the stimulation starts here, it travels through all of this, and once it gets down here and here, is when that electrical impulse fires and shoots, right? So it goes down and it shoots once it gets to the bottom. The electrical impulse does, in fact, start up here. It's conducted, and once it gets to these cells, the cells at the bottom or the apex or the excitable ones, once those hit, then the EKG fires, or the electrical impulse fires off and turns it into a mechanical contraction. The SA is electrically connected to the AV through the atrial walls, which we went over. Your AV node also polarizes spontaneously. This book is going to say 40 to 60. I'm going to say 60 to 80 or 50 to 80, somewhere around that range. Any of those will work. If you see it, I'm going to tell you right now, if you see it on a test for here, 40 to 60 will be the answer, just because that's where your test bank comes from. So if you want to know, for testing purposes, AV will be 40 to 60 in reference to your book. Real life, it's a little bit more than that. Normal contractions stimulated by the SA occurred before the AV cell depolarized to the threshold spontaneously. If action potential is not received from the SA node, the AV node becomes the pacemaker of the heart. It establishes what your book is going to say is a rate of 40 to 80. If you have, and I'm going to say this, if you have a heart rate of 80, but there's no P waves, it's probably the AV node, right? If you have a heart rate of 55 to 60, 50 to 60, somewhere in that lower threshold, higher threshold of sinus Brady, lower threshold of sinus, it's probably also starting from the AV node, and it got excited by the SA trigger. So it's going, not that clinically you're not going to treat differently depending on where it's firing from, just on the underlying rhythm that it is, but just for peace of mind, that's for what that's worth. AV is located at the floor of the right atrium, near the opening of the coronary sinus. Action potential travels through the bundle of His, which will be this. It's where these two main bundle branches are conjoined together. Bundle of His is where the conducting cells start. They extend along the intraventricular septum, which is what? That divides what? Yes, your left and right ventricles. About a third of the way down, that bundle of His starts to divide into separate strands, noted as the left and the right bundle branches. The bundle branches radiate across the innermost surface of the ventricles and transfer impulses to the Purkinje fibers. Again, think of the Purkinjes as the capillaries of the nervous system in the heart. Your Purkinje fibers are specialized cells that convey impulses to the contractile cells of the ventricular myocardium. So again, once they reach that apex and those Purkinje fibers start to spread out, that is where that impulse is going to initially fire from, is from those Purkinjes, and then it's going to conduct its way back up. That is what causes, and by back up, I don't mean back up the bundle it is, I mean back up towards the top of the heart, because as you can see, those Purkinjes wrap all the way back to the about where the atrium start, or the atrium ventricles separate, right? So they're going to travel back up, and that impulse is just going to cause those ventricles to squeeze back up into itself. Action potential takes about 50 milliseconds to travel from the SA to the AV. We should know how all that stuff that conducts down those pathways. And as you can see up here, once it fires down there, it's going to travel across this membrane here. That's going to include mainly the right, but also the left ventricle. But again, does the left ventricle have to beat a bunch? No, because it's going to get supplied by the contraction of what? The right ventricle, because as the right ventricle contracts, it's going to push that blood back into the left atrium. All the left atrium needs to do is push that slowly to fill that left ventricle for the ventricular contraction. The initial impulse only affects the atria. There's that fiber skeleton that we talked about earlier that kind of holds it in place, actually separates the electrical activity between the atria and the ventricles. The only place it doesn't is where you actually have the bundle of His, because that's just a big network of conducting tissue that actually passes in and out of that fibrous tissue. The impulse slows down at the AV node, takes roughly double the time for it to pass through the bundle of His, the AV bundle. That delay allows the atria to contract and move blood to the ventricles. So that, obviously if it was quicker, And that's what happens when you have a high heart rate. You know, if the patient's heart rate's 190, we have to slow it down. Why?
So before it has time to actually.
Because there is no time for refill. There is no preload. It's going in, and it's as soon as it's coming in, it's pumping it out, and it's not moving a whole lot of blood. While the heart rate's extremely high, the volume of blood per contraction is limited just because just think of it. If I have 1 second to fill a glass or 5 seconds to fill a glass, which one can I put more water in? 5 seconds, right? Same concept here. If there's not enough time to delay that impulse, the ventricles are not filling.
So I had a patient the other day that had a heart rate of between 150 to 200. She was in AFib with RVR, had a history of AFib, and all the medic did was give her 5 nitro.
Your medic did what?
It wasn't my medic. It was a Tri-Township medic. But he gave her 5 nitro, he didn't give her anything else. And I was like, there's nothing else that you can do for this heart rate? He said,
For
no.
AFib RVR. Don't ever do that.
Yep. I made sure to let the hospital know that it was not me.
So the heart rate was 150 to 200, and we gave nitro.
5.
No. I would like to see your protocol. I'd like to see a protocol that allows 5 nitro administration, regardless of what's going on. However, so nitro affects preload. Preload is how much blood is in the heart for it to pass on to the next contraction. So with a heart rate of 200, we already have reduced preload. And then I gave a medication 5 times that reduces the preload. Because what does nitro do? It dilates your vascular system, which means bigger hole, same amount of blood, less blood returning per bump.
I said, can you not give her cortisone? He said, Charity takes it.
And?
I'm just here. You run.
Why would he use
So,
Pressure in
this is my goal in this class. We had 23 people apply to this class. I took 15. I'm a quality over quantity type person, and my goal is to not put medics like that on the street. So that is my goal in this class. I don't know who it was, and I don't want to know who it was. But don't do that.
Why though? Like, why would you give nitro for
Nitro affects blood pressure, not rate. And when you lower your blood pressure, it's going to increase the rate.
Yep. She couldn't have went much more, so.
Well, that sounds fun. Anyways,
Someone needs to call a mirror. That's fucked up.
stimulus to begin a contraction, it reaches the ventricle muscles. This takes another 75 to 100 milliseconds. Again, you can see, once it gets down to the Purkinje's, it excites those bottom fibers, and an electrical impulse contracts back up towards the top. The whole time was roughly 200 to 300 milliseconds per electrical conduction from start to finish. Deviations from the normal pacemaker. Bradycardia is when the heartbeat is less than 60. Tachycardia is when it's more than 100. That's one thing the book and I can agree on. 60, less than, is bradycardia. More than 100 is tachycardia. That should be knowledge by now, but if not, we'll... you can also, the body can override the SA or the AV node. This is caused by abnormal conducting cells or ventricular muscles. Again, you can have that runaway diesel type thing where no matter what you're doing, your body's not listening to itself. So AFib RVR, does anybody know what the RVR stands for? So with rapid ventricular repolarization, what is happening? They're not conducting as hard, right? So your body is saying, not enough blood, go faster. Because it's repolarizing quicker because it needs more blood quicker, right? So for us to correct that, we have to slow that rate down and increase the excitability of those cells to slow it down and then squeeze harder. Like that is our goal. Not dilate cells, squeeze harder and move less. That'd be bad. It's counterintuitive. So we're
5
patient.
nitro is the...
But yeah, everything is 5 nitro. Especially if they're dead, just let them dissolve in their mouth as you do. Drop it down the ET tube, right in the lungs. Don't do that. Write that down. That's my favorite guy. Action potential may completely bypass the conducting system. Again, we're talking about ectopy or ectopic beats. You can have excitability that's not within the SA or the AV node that will still conduct because they're close enough to the pathways. Disruptions of ventricular timing or contractions, again, RVR is a big one. Your VTAC is a big one. VFib is a really shitty one. But there's different ways for that to happen. We can all diagnose it with an EKG. Again, 4 leads can give our underlying rhythm. 4 leads are non-diagnostic. No treatment, 0. 0 treatment should ever be done off of a 4 lead, unless it's confirming a systole lead. That's it. That's it. Non-diagnostic. Never look at them. Never look at a 4 lead and go, they're having a STEMI. Never look at a 4 lead and go, they have a bundle branch block. Never look at a 4 lead and go, they're in VTAC. They probably are, but it's still not a diagnostic. Take the extra 30 seconds and CYA, especially if they're talking to you. If not, you put them on pads. Pads are in fact diagnostic and send electricity, so then you can solve the problem. An electrocardiogram is a recording of the electrical activities of the heart. Again, just because it's happening on an EKG doesn't mean it's what's really happening. It's what's happening on the electrical side of the heart. Our job is to confirm that it is in fact doing what it says it does on the mechanical side of the heart. ECG or EKG, they're transposable. I use the term EKG, you might use ECG, they mean the same thing. Each time the heart beats, a wave depolarizes through the atria. It reaches the AV node and travels down the interventricular septum. It reaches the apex right there and turns into depolarization. During this time of depolarization, the atria is also repolarizing, and then the ventricles repolarize. I don't know why there's this fucking W wave after this, but that's weird. But yeah, like we went over, you need to know that. It's helpful to know it now so you understand what is happening. Especially because I believe right after this is pharmacology. After the bullshit of like, be a good paramedic, right? Is that right? Am I wrong? Yeah, that's just patient assessment, then we go into pharmacology. It's good to understand how the heart's working when we're dealing with medications. It's actually quite important. Electrodes are placed at different locations on the chest. In case you didn't know, we didn't stack one on top of the other. You compare information that's compiled from that. This is the most useless slide we've completed yet. It can diagnose damaged heart tissue through depression or elevation. Those affected muscles are no longer conduct in action potential, meaning it cannot contract itself, right? EKG can reveal abnormal patterns or impulse conduction, bundle branches, delays in prolonged QT intervals, prolonged PR intervals, prolonged R-to-R intervals, all kinds of things that we'll get into in cardiology. But it's super, super diagnostic if you do them correctly. And again, when in doubt, 5-nitro out. Appearance varies with placement and monitoring of the electrodes. Contrary to popular belief, the electrodes that your provider buys is actually quite important. If your provider buys cheap electrodes, you're going to get shitty EKGs. That's one thing. I will die on that fucking mountain. For the ones that buy those paper ones, or the ones that buy the ones that every time you rip the fucking plastic off, the node comes with it, you're like, I need another one. Those are dumb. Buy good ones with foam, buy good ones with lots of lube. The more jelly, the more fucking conductivity that there is. And for you, if you're a fucking heathen that preloads your fucking cables, stop. Stop today. You're a heathen, and you're doing yourself and a patient a disservice. Stop preloading your cables because you're lazy. Because what is air going to do to that jelly? And what happens when it dries out? Less conductivity to impulse. Stop preloading your cables. Fucking pet peeve of mine.
So preloaded
Wow.
cable.
Preload your cables as you're giving 5-nitro. All of it. For real, stop it. In a serious thing, you're going to think, that's not that fucking big of an issue. I do a run every 12 minutes, it's not going to dry out until it doesn't. Or until that protective covering flops off, or you're the type of person that rolls them up like a fucking mongoloid, like you just made a balloon animal, and your partner's sitting there trying to untangle this woven fuck of fuckery, and 9 of them fall off on the floor and you have to replace them anyway. Just stop. Just stop. The things are referred to as leads. There's a standard configuration, meaning there's only one fucking way to do it. Otherwise, it's going to give you aberrant readings. I already told you what that means. I already told you what that means. I already told you what that, look at that, we're ahead of here. Atrial repolarization is not visible because it occurs while the ventricles are depolarizing. And since the ventricles are bigger, bigger wave make little wave go away. Doesn't mean it's not there, it just means it can't be seen. My 1-year-old stands behind me, you'll see me before you see her. Same concept. Not her, because she'll probably bite the back of my leg and do something stupid, and I'll move and then you'll see her, but same concept. Oh, I see what's going on. So, this is the pathway without the heart, right? At the SA node, when that fires, you get the beginning of the atrial depolarization, which is the P wave. You get the end of the atrial depolarization as it reaches the end of the AV junction, and then you get ventricular depolarization once it passes through and gets to the Purkinje fibers, and then you're going to have that ventricular repolarization. That's on your page, I assume in your book somewhere, something similar maybe?
I can't find it.
Okay, well, luckily this is recorded and you can go back and look at it later in your free time. Measuring the size and voltage changes. Small electrical signals may mean a decreased heart muscle mass, or you're a heathen and preloaded your electrodes and they don't have the same conductivity as they did when they were in the package. That's a big thing too. Excessively large signals may indicate enlargement of the heart, or you were overzealous and put more jelly on your electrodes before you put them on. Don't do that. If you ever are in a situation that for some reason you have ultrasound jelly on your truck and it won't conduct, you can use ultrasound jelly on those electrodes and that'll help with the conductivity. Fun fact. Determining the temporal relationships of the various components is important. Those EKGs are used to detect and diagnose cardiac arrhythmias. Again, 12 leads, not 4 leads. Abnormal patterns of cardiac activity. Now, one thing you can diagnose off of a 4 lead, again, but it has to do with the underlying rhythm, is the AFib versus the sinus tach versus sinus Brady. All of those things you can diagnose on a 4 lead, because I don't need 12 leads to tell me I don't have P waves. I don't need 12 leads to tell me my rate is 42. So they're diagnostic on underlying rhythm, not on treatment. So you don't need to run a 4 lead because you're like, oh, that's 46, but sinus, you don't need to put a 12 lead on just like it is in fact sinus breaking. If their heart rate's 46, you should do a 12 lead, but you don't have to do it to call it sinus breaking. Cardiac arrhythmias, what's the difference? Does anybody tell me the difference between arrhythmia and dysrhythmia? Anybody know?
Bad versus
No.
no.
One sustained, one not.
Huh? One is electrical in nature, and one is not necessarily mechanical, caused by outside sources. So lack of oxygen can cause a dysrhythmia. Whereas an arrhythmia is damage to the area that electricity cannot be conducted through. Make sense? Those merge are not transposable, contrary to popular belief. Cardiac cycle. The period between the start of one beat and the start of the next is one cardiac cycle. So from here to here is a cardiac cycle. Right there to right there is a cardiac cycle. Includes both contraction and relaxation. Each chamber of the heart can be divided into two phases. Systole and diastole, or systole and diastole, or diastole, whatever you want to call it. Systole is the contraction, or systole is the contraction when the chamber squeezes blood into an adjacent chamber or arterial trunk. Diastole or diastole is the relaxation. That is the time that the chambers fill with blood and prepare for the next cycle. So, what is that? What are those two words very similar to? Well, this is also close to that, which would be zero, but
Systolic and diastolic.
systolic and diastolic. So that means my systolic is my top number, is when my ventricles or ventricular contraction occurs, right? And my diastolic is when it is at rest. Those are the two numbers that are represented on a blood pressure. That's the only way to move fluid, is from high pressure to low pressure. I'm not going to go over that again. The cardiac cycle begins with atrial systole or contraction. Ventricles are already partially filled with blood, roughly 70%. Atrial contraction completely fills the ventricle. Atrial systole ends, atrial diastole and ventricular systole begin and happen at roughly the same time. Obviously, with the ventricles being bigger, the ventricles overtake what happens, and the pressure rises in the ventricles, and with that pressure, those atrioventricular valves slam shut, hopefully not allowing regurgitation. Ventricular pressure must exceed atrial pressure for blood to move. That means my bottom number can't be bigger than my top number. Or it go backwards. Not really, it just doesn't go forward. Wouldn't that be? I wonder if that could be possible. Can you flow blood back? No, that'd be real bad. Answer my own question. Blood flow is continuous for the duration of the ventricular cycle. So the entire time that your ventricle is compressing, blood is moving. Now we all know that the blood that starts in my heart, when it contracts, doesn't do one circle in one beat, right? So it moves, it moves, it moves, it moves. And that's why we have valves in our artery system, is to keep it from backflowing back into the heart. Ventricular diastole begins. Obviously during that time, the pressure rapidly declines because they're doing what? They're relaxing, right? Those semilunar valves close when the arterial pressure exceeds ventricular pressure. Ventricular pressure continues to drop and eventually falls below the atrial pressure. Those AV valves open. That allows blood to start flowing in to the ventricles to pre-fill until there is an atrial contraction. Again, the blood flowing from the atria to the ventricles without any of this shit happening. So between this time and this time is a passive process when both the ventricles and atria are in diastole, meaning none of them are under contraction. So at that point, blood is starting to flow in to the left ventricle. It's just kind of drippy dropping at that point because it's not a pressure change, it's just what's in there from the prior contraction. Because when my ventricles just beat, what happened? My atria started to fill up with blood, and now all that stuff's going into the heart until the atria contracts and pushes the remaining part out. That is on page 479, more reference. Contrary to popular belief, your heart has more than 2 sounds. It in fact has double that amount. It has 4. You have S1, S2, S3, and S4, also known as the lub dub. That lub dub is accompanied by the actions of the heart valves. The first part is introduced when the AV valve closes and the semilunar one opens. The second part is when the semilunar valves close. Third and fourth heart sounds are faint and seldom detectable unless you have a stethoscope that has auditory enhancement. They're associated with atrial contraction and blood flowing into the ventricles. All this is important, so pay attention or wake up. Stroke volume is the amount of blood ejected by one ventricle. It obviously can vary beat to beat depending on what your body is doing at that moment. So stroke volume is the amount of blood ejected by one ventricle. Cardiac output is the amount of blood pumped by each ventricle in 1 minute. This will give you the amount of blood that is flowing through your vascular system and into your peripheral tissue. So how do you think we figure out cardiac output? Huh?
Preload.
What?
It's in the book, heart rate versus,
Don't mumble.
Huh?
Stroke volume times what?
Heart rate.
Exactly. So, if your heart rate's 100, your stroke volume is 10, what is your cardiac output? Exactly. How do you measure stroke volume, you ask? You can't. But we go by a general rule of thumb. There is the formula for cardiac output is ml per minute, and that is stroke volume, which is ml per beat, times heart rate, which are your beats per minute. Your cardiac output is roughly equivalent to the total blood volume of an average adult, meaning within every minute you should circulate all the blood in your body. It is highly variable. Obviously, if my heart rate increases by 20 points or drops by 20 points, you're going to have an increase or decrease respectively. Rarely does your stroke volume change unless your body has a higher demand for oxygen or blood supply, or there's blood loss. Factors controlling cardiac output, regulated by the peripheral tissues that receive that blood supply and say, I need more, I need less. Major factors that affect both heart rate and stroke volume. Obviously, blood volume. If you lose less, it's going to increase your heart rate and decrease your stroke volume. Autonomic innervation and your hormones. So if your hormones are saying, I need this, or my kidneys are doing this, or my kidneys have a huge adrenal dump, what's going to happen? My heart rate's going to increase. My cardiac output is going to increase because my heart rate increases. So it's all dependent on what your body needs at any given time. Secondary factors, ion concentrations and extracellular fluid and body temperature. Again, if we all go stand outside in a bikini or Speedo and it's 12 degrees outside, what is our body going to do? Well, not just shiver, but it's going to shunt blood. It's going to bring that to our kidneys, lungs, heart, and brain, and it's going to slow it down because it's saying, you know, it's going to slow down because it's only now perfusing to 4 main areas. It's not doing all the other shit. So it's going to say, hey, I can slow this down. I'm going to contain energy, and I'm only going to perfuse where I need to perfuse. With blood volume reflexes, the cardiac muscle contraction is an active process. Relaxation is passive, just like every other muscle contraction. Force required to return, relaxation is the force returned to the cardiac muscle to pre-contracted length. So during that entire time is when the relaxation takes place. Your elasticity of that skeleton that your heart has helps with that, as well as the blood coming back to the heart, filling those chambers, allowing the pressure to increase, allowing the muscle to expand. There is a direct relationship between the amount of blood entering the heart and the amount of blood ejected from the heart. It can't eject more than it has. Very rarely will your heart underutilize the amount of blood that it has either. It doesn't just keep half of it in reserve just because it can. Two heart reflexes respond in change in blood volume. The right atrium reflex affects the heart rate. The ventricle reflex affects stroke volume. Know those two things. Yeah, sorry. Good. Your atrial reflex is also known as the vein bridge reflex. It adjusts the heart rate in response to venous return. So it adjusts your heart rate off of how much blood hits your right atrium with that ventricular contraction. What has valves? Your arteries or your veins? Veins. Why? Yeah, compensate for gravity. And your arteries are under what? Higher pressure than your venous side, right? So your arteries are going to, now I'm not saying that there's not an artery that doesn't have a valve, most don't. But since it's under higher pressure, it's just moving as it needs. The venous side is under lower pressure, so if it's trying to beat back up to come up my vena cava, it'll just sit there and kind of turn into just stagnant blood. It would just pour in with every beat. That's not very productive. Your vein bridge reflex is the entry of blood stimulates stretch receptors in the right atrial wall. You'll have an increase if the heart rate is triggered from the sympathetic activity as well. Your what? Put them up and fight, right? Your fight or flight reflexes, if there's anything there, you'll have an increase in heart rate. With that sympathetic activity, that stimulation causes an increase in the SA node discharge, meaning it's just going to fire quicker. Stroke volume depends on, obviously, venous return and how much time there is between each heartbeat to fill. There's going to be significantly less time filling if my heart rate is 150 versus if it's 80, right? Filling time is dependent on the duration of ventricular diastole. Again, it's going to be heart rate dependent. And like I said, the faster the heart rate, the shorter the time is for that to refill, because it's going to start a cycle all over again. Changes in venous return can have alterations in cardiac output, can have alterations in peripheral circulation. I feel like that last one can go unsaid, but if not, factors that affect blood flow through the vena cava. Obviously, if there's less blood coming up the vena cava, we're going to have less what?
Venous return.
Exactly. Starling's law, more in equals more out. Old Frank.
That's how all Kentuckians pronounce my name.
And Mike Spurgeon.
Yeah.
Starling.
Starling. Yeah, this is on the registry.
Starling's law. Oh, it was hit hard on mine too. The greater the volume that enters the ventricles, the more powerful the contraction has to be. And with that, the more stroke volume that you'll have. And with more stroke volume, you'll have what? Thank you. 2 stars for you. Venous return increases. With more venous return, you're going to have more ventricular filling. And more ventricular filling, you're going to have a greater ventricular contraction because it has to get more blood out. Again, what comes in must go out under Starling's law. Autonomic innervation, SA node, pacemaker cells establish your basic heart rate. That rate can be modified by your nervous system. And it can be controlled by both your sympathetic and your parasympathetic. Your fight or flight or your feed and breathe. Fight or flight, it's going to do what? You're eating or looking at the sex of your choice unclothed, it's going to do what? Well, I mean, it might increase for a second, but it'll decrease eventually, right? You're in a place of pleasurability, you have that serotonin release, it's going to drop your heart rate. Postganglionic sympathetic fibers extend from neurons into cell bodies in cervical and upper thoracic ganglia. That's with your sympathetic. You have preganglionic parasympathetic fibers that carry along the vagus nerve and extend to the small ganglia near the heart. So the ones are going to increase and the other are going to decrease. Because what happens if we have vagal nerve stimulation? We have a vagal stimulation.
Heart rate drops.
And our heart rate does what?
Drops.
Everything go down. Pass out pooping. Your autonomic nervous system division, you got innervate the SA and AV nodes, and then obviously your atrial and ventricular cardiac muscles. So you have a separation between the two while working together. That's on page 483. You can see where you'll have those responses from both the parasympathetic and the sympathetic side. You have your vagus nerve, you have your ganglia that come from your spinal cord, all of those things. Autonomic effects on the heart primarily reflect the SA node response to ACH and norepinephrine. ACH is going to do what? It says it on the slide. Lower the heart rate. That is your parasympathetic response, while your norepi is going to do what? And that's going to come from where? Typically. A little hat. Thank you. 2 stars for you. With sympathetic activation, you're going to have a sustained rise in heart rate from the adrenal medulla that release epi and norepi. Again, that is located where? Huh? Which is located where? On the top of your kidney, like a little hat, a little dunce hat. Huh?
Because the adrenaline will make you do dumb shit.
Exactly. In respects to stroke volume, a release of norepi, epi, or ACH, again, up or down. Whether it's up or down, it's going to alter the force in which you have a myocardial contraction, whether it's more force or less force. More force is going to be applied by which ones? Correct. And your less force is going to be stimulated by what? Correct. Sympathetic release of norepi in the myocardium, the release of norepi and epi by the adrenal gland stimulate the cardiac muscle, increasing the force and degree of contraction. And with increased force, you're going to have increased stroke volume. Your parasympathetic gives an ACH release. It's almost an inhibitory reaction that results in a decrease in the force of the contraction. You'll see the greatest reduction in force occur in the ventricles. And with a decreased force, you'll see a decreased what?
Stroke volume?
And then, yep, stroke volume, and then subsequently a decreased cardiac output. Blocking of the vagus nerve is going to increase the heart rate. And blocking of the sympathetic nervous system is going to slow the heart rate. So while stimulating both are going to have the adverse reactions, blocking those are going to have adverse reactions of what they normally do. What would those, anybody know what those type of medications would be called? Not specifically, just, it starts with an A.
Antagonist.
Antagatory drugs. They're going to fight against what it does. So if I have something, if I'm trying to slow the heart rate, that is going to be an antagonist to the sympathetic nervous system. Or if I'm doing something that is going to block the vagus nerve, I'm going to have an antagonist to the parasympathetic nervous system. Or you could have ones that are agonists that enhance the parasympathetic or sympathetic nervous system. Cardiac centers of the medulla oblongata, which are located where? What part of the brain? Correct. Your cardio acceleratory centers activate sympathetic motor neurons, and your cardiac inhibitory controls the parasympathetic motor neurons. Inhibitory slows, acceleratory accelerates.
Will you go get that TV stuff out so it warms up, that way it's not ice fucking cold when we're giving it to them, and get me
13. Shauna, you don't need one. You don't need one. Anybody else not need one or can't take it because they have a reaction?
get 13 plus 2 in case one of us wants it. Yeah. Grab a couple alcohol preps, grab 30 alcohol preps, and get Tyler ready. We'll have to make copies. You can do it right here. Cardiovascular information arrives at the cardiac centers, the sensory fibers from the vagus nerve or the sympathetic fiber nerves of the cardiac plexus. That's where it'll receive its response from, either the vagus nerve or the cardiac plexus in the sympathetic fibers. Can you go back real quick, sorry, it was on the slide that cardiac center's response will sense a change in blood pressure or the amount of dissolved oxygen and carbon dioxide in the ABGs of the body. And with those changes, it will send the stimulation to either the sympathetic or cardiac plexus or the vagus nerve to either increase or decrease. It monitors baroreceptors, which are what? Pressure. And chemoreceptors, which are what? pH, hormones, all of those things. Innervated by the glossopharyngeal and vagus nerves. Monitor for a decrease or increase of blood pressure and or oxygen and or carbon dioxide.
indicates the amount of oxygen demand those tissues are going to have. So obviously, if there's an increase in oxygen and a decrease in carbon dioxide, I'm having less gas exchange or less need for what I've got. If I have a decreased oxygen level and an increased carbon dioxide level, what do I need to do? Pump faster or get more oxygen, right? Because it's trying to balance out. So if I have more free radical oxygen and less carbon dioxide, my body's not doing a whole lot. Where if I have the adverse reaction of it, it's going to need more. On this sense, if there is a decline in oxygen and an increased carbon dioxide, it's going to increase the cardiac output because it needs to filter that waste out and get more oxygen to that peripheral tissue. You have hormones, thyroid hormones, and glucagon also increase the force of contraction. Digitalis, I'm sure we've all ran into a patient that's on DIG. It's becoming less and less frequent, but people are still out there on DIG. That increases calcium concentrations, excuse me, and with increased calcium concentrations, what is that going to assist in? Better contractions of the heart. You have antihypertensives, which negatively affect the contractility. So hypertensive means what? High blood pressure. So if I have an antihypertensive, it needs to lower that blood pressure, so it's going to reduce the contractility of the heart. Any questions, concerns, comments, or anything that I can clarify? No? Hour? Let's get this TB stuff done so we can get it done. If we can go to the next chapter, and we'll go into the next chapter. You will come to us. I don't care which order we do it in.
Thank God this morning.
Tyler, what size gloves do you need?
Come out. Large one. Come out in his underwear and ragging.
Did he at least have a gun or something?
He had one earlier. He left it inside.
You know, we still have it.
Come on. Aren't you all supposed to do that? Who has had one in the last 12 months? You? All right.
I'm doing the last 6 because by the time we get to clinicals and some of those sites, I don't want it to run out.
Okay, who's had one the last 6 months?
The only ones that have should be Kron and Deshaun.
So if you get you that on.
So it's all for nothing.
Huh?
It's all that for nothing.
Well, no, you're still good because theirs said within the last 12 months, so at the time, because you're still good to October for your 12 months, so you're good.
What was it doing?
Okay, I'll give it to them, that way they can fill it out.
Three L's likes to.
Let me check what.
She's got 4 cavities.
Yeah, what?
4 cavities.
Awesome.
Gonna have to have 2 separate,
Home door. How else can we fill out for
They have what?
have to have 2 separate.
Just fill out the top part, please, leave the, everything from
And they're all permanent.
information down.
Are they really?
Yes.
You will not be my 13th reason why you.
I have a vial of syringes. And if you want to fill out the paperwork, just keep streamlined and sign them. Get time down. What's your lot number? Mine's 2CA30C1.
2CA330C1, yeah. Dude, I need to go to the doctor.
Can you repeat that one more time so I can write it down?
All right, everybody under lot number, I'm going to read this to you. Please put it down. 2, Charlie, Adam, 3, 0, Charlie, 1.
Thank you. Does it ask for an expiration?
Yes.
6, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 0, 825.
It also wants to know manufacturer.
Manufacturer is going to be SANOFI. Two C8, 30 C1. Anything else at Axford?
Just who you are.
Well, she'll fill out all the rest of that under,
You want the address here?
yes. If you would put the address for here, 1468 Scott Valley Drive.
Ah, if I already fucked that up.
If you already fucked it up, just leave it.
Okay.
Is it? Oh, god dang.
Yeah.
What's the zip code here?
47170. I will say, don't push these all the way in while it's in.
I'm on. There to the.
No, I'm talking about the plunger.
Oh. Oh, yeah, it comes out.
Yeah, it'll retract while it's in the wrong.
Can we pick which one he does ours?
Yeah.
Based on that conversation?
You just to like step up and do.
Yeah, just form a call.
Don't hand me your paper until you're getting it done.
Pass out.
I can't promise that.
Which one? Underneath.
You don't have a
Feel
T-shirt
it.
on?
Yeah, same.
That one? Oh, it's my first one.
First time calling you.
Now it's within 48 hours.
Get this red. Put it in.
Trying to put the name.
Don't squish it.
Switch it.
Don't squish it. Don't rub. Just pat it. Don't rub it.
If you need a paper towel, it's there.
You got bit by a big ass skeeter, yes. Thank you for staying for me for like 30 minutes. What?
You'll just watch it for a reaction. After a couple of days, it might get a little puffy, but you'll notice if you have a positive reaction.
Medic and one of our EMTs got arrested, so.
Huh?
You look at me. Why? They got caught falsifying a run report, and they think it's a big deal.
So this should be a big deal everywhere.
Yeah, I don't think location matters.
They signed, they put on the run report that there was no patient found, and then PD.
Hold on to
bike
these.
clearly-
Actually, yes. You, Amanda, take yours with you. Have Jacob or Steve sign off on yours, please. Everybody else, leave them here. Because I don't want to be like, I forgot my paper.
Sterling, bring yours back and
I've never heard when you're talking about don't put it all the way in.
Huh?
Like the plunger because it disappears.
Yeah.
And down here. Give me a second.
who's next?
It's fine.
Yeah, everybody's getting handed for it because people fly on run reports.
Who did that? Is their name Ryan with Webben?
No.
I'm sure I could do it.
So you don't matter, that have to do work.
She need another one on top of her other one?
Oh, good.
forearms, you're just gonna be like, nah, there's not enough room.
Holy shit balls. It's tight like a tiger. No veiny areas.
Other arm.
Let me see your other arm. Holy shit balls.
I guess even better.
Yeah, let me go down here in the wrist.
Like with the wrist.
Just put it in his fucking hand. Yeah, you can tell all the methods that you
Shit. Why don't you go with me,
I don't have a weight. How many you done over there?
3. Well, how many you got?
1, 2, 3, 4, 5, 6.
It's been a hot minute since I've done this.
I don't know, weekends are already.
I go down to the clinic and shoot up people. I'm too scared, I got it. I'll shoot that.
Then you can give me some fun.
The one hole. Well, I do that on all of them. So I go.
I ran out of needles.
I got plenty. But really, I'm slow as hell.
Alright. I'll send you a picture of my arm the next couple days, because I'm gonna be in Tennessee.
Yeah.
Which one did you get done?
What's moving so much? Over there.
Rabbit, which one were you?
Right. To be fair,
Oh, I know why.
Tyler,
I'm reusing the whole needle the whole time. That's my problem. I'm just joking. Who said what? You running your mouth over?
Tyler, this is your alcohol spot.
Yeah. You can't get phlebitis if it's not in the tissue.
I've been giving IM. What have you been giving?
Nobody's left?
I didn't like Nick Candy, so.
Well, he ain't got to wait, so you got somebody over there.
Everybody done?
Well,
You done?
we were
Just
struggling.
me. Why you sitting there smoking cigarettes?
It's just me.
We had a water rescue one time.
Well, don't
He
get me
shows up.
sick.
You don't be disrespectful. He shows up in his onesie, water stick, and his chain's hanging out. Stand back with a professional table and over. You sure look it, buddy.
Yeah, sounds like it on there.
How did you say you're here tomorrow? Or not tomorrow?
Yeah,
Friday.
if you have issues getting up here Thursday or Friday, please get with me prior to leaving. If not, I expect you to be here Thursday or Friday, Thursday before 5:30, Friday anytime. I mean, not 10 o'clock at night, but you know what I'm saying, to be ready. If you have an issue getting up here and you have someone at your service that can read it, they need to call me while on the phone, read it, and I'll get the stuff over there.
You ready now, right? So, I did 5. I didn't feel a thing. Here's my 5. I'm on my 5.
I don't know if you're Harry Potter fan, but I hope you never see that.
You see what? Okay, so yours went flat too. Mine went the same. Mine went the same bubble.
Pumpkins over here, fucking vanilla Sicilian.
I was not kidding. Yeah, I was very, very, very.
I'm already
That's right, on hers, I got.
Always good.
Does anyone have a payment besides Eric?
It's the first of the month.
You already talked to her?
All right, do we want to get into this chapter for the next 40 minutes, or what do we want to do? Do you want to read it on your own for homework and be responsible for it? And I'm going to test you over it.
There it is.
What is it?
It's the cardiovascular system and blood vessels.
It's your heart. Yeah.
I'm down to clown either way.
Well, if it needs to be the test, I'd rather just sit through it. I don't want a test.
That chapter.
I mean, we have a test on it.
Yeah, it doesn't relinquish the fact that you have a test.
I think like a quiz, like when we come back. We have a quiz.
We have a test next week, right?
No.
So it's all-
We have a quiz.
Oh, you'll definitely have a test next week, or a quiz next week.
Oh, really?
We have a confirmed quiz
I
next
don't know,
week.
I've made it yet.
Thank you.
I just assumed based on the information that I
I'm
have.
not taking this.
Are we not doing chapter 9?
Yes, we get to it. What is it?
It was supposed to be last week.
I've taught 3 of these.
Okay.
I've managed them. What's the consensus? Who wants to do it by themselves? Raise your hand. 1, 2, 3, 4, 5, 6, 7. Okay.
I kind of want to see how that works. Draw some blood, kind of curious what
I would love to hear you talk about color blindness, so we can go to chapter 9. I explicitly did not read that chapter. I was like, oh, Nixon covered.
No, he's not. Yeah, I will. I want to get through, the reason that I skipped it is because I wanted to get through the 2 we've been through today. We're going to start with respiratory next week and then hit digestive, and then we'll go to the other 2. It's whatever you want to do. I don't know. I'm going to breeze through these real quick and see what. You do need to know those 3 things. Highlight them in your book. Interna, media, and externa. That would be really important to know and what they do.
What was the sternum, media, what else?
It's on page 490.
External media and internal.
Huh?
What? I think you guys can probably handle this one on your own.
Crush your students.
It's a long ass chapter.
All right, so you guys want to do it on your own, that's fine. There's not a whole lot of anything in this one. Questions, concerns, comments? Homework's going to be to read chapter 13, question mark? Is that what that is? Okay.
Is this one?